Hey, future nurses. Welcome to today's Explainer, where we're going to tackle a massive foundational shift in your clinical practice. Our main mission today? We're shifting your clinical mindset completely away from those standard adult baselines you've spent so much time memorizing, and we're opening your eyes to the very unique, very specific physiological realities of pediatric care.
Okay, let's dive into this. Here's our systems-based roadmap for today. 1. Not just little adults. 2. Cardiopulmonary and blood. 3. Processing and elimination. 4. Structure and skin. 5. Neuro and cognitive development. And finally, 6. Pathologies and takeaways.
Starting right off with Section 1, not just little adults. This is a total paradigm shift.
Here is your ultimate pediatric nursing mantra. Seriously, write this down. Children are not just little adults. They have entirely different physiological baselines. You literally can't just take adult care or adult medication dosages and scale them down. It doesn't work that way. Think about a newborn for a second. Their head is proportionally massive and heavy compared to the rest of their body. Their cells are dividing at this incredible exponential rate compared to a mature adult. From a lack of tear production in early infancy to just having zero voluntary control over their environment, everything, right down to the cellular level, is completely different.
Moving on to Section 2, Cardiopulmonary and Blood Systems.
So, as an adult care nurse, you're super used to seeing a resting respiratory rate of, 16 to 20? And a heart rate around 60 to 80 beats per minute. But in a neonate, you're looking at a respiratory rate of 30 to 60 breaths per minute and a heart rate of 100 to 160. If you saw those numbers in an adult, you'd absolutely be calling a rapid response. But in a newborn, that's just a regular Tuesday. Also, keep in mind that pediatric respiratory tracts are incredibly delicate. They just don't produce the same thick, protective mucus that adults do, which means they have vastly less protection from infectious microorganisms trying to invade.
Let's see how this plays into the hematologic system. Adult red blood cells are macrocytic and stick around for about 100 to 120 days. But in newborns' red blood cells, they are microcytic, meaning they're much smaller, with a mean corpuscular volume under 80. And they only live for about 60 to 90 days. On top of that, a neonate blood volume is about 85 milliliters per kilogram of body weight. That's significantly higher than an adult's 60 to 70 milliliters per kilogram. So they're cycling through much smaller cells at a way faster rate.
Now, what's really interesting about this is the absolute magic trick the cardiovascular system pulls off the moment a baby is born. Look at the stark contrast between fetal and adult circulation. In utero, gas exchange is happening in the placenta, not the lungs, and pressure is actually highest on the right side of the fetal heart. But the exact moment that baby is born and takes its very first breath, the entire system rewires itself. The lungs instantly take over gas exchange, and the pressure shifts permanently to the left side of the heart. It's a massive systemic change, and it completely underpins what you're looking for in your initial newborn assessments.
All right, Section 3, Processing and Elimination. We're talking the GI and GU systems here.
Let's compare the kidneys. An adult kidney is fully mature, right? The nephrons function properly. An infant's kidneys, on the other hand, are highly immature. Their nephrons haven't fully grown yet, which means infants simply cannot filter or concentrate urine effectively. And this is exactly why meticulous fluid tracking is absolutely crucial in the hospital. Their urinary elimination is entirely involuntary, and they just lack the mature renal function needed to compensate for any sudden fluid shifts.
Moving down to the GI tract, we adults have a pretty tight cardiac sphincter at the top of the stomach, keeping our food down. In infants, it's really relaxed. And this direct anatomical difference is exactly why you see such frequent, and I mean frequent, regurgitation and vomiting during infancy. Top that off with a liver that is proportionally massive, making up about 4% of their entire body weight, and entirely involuntary, immature GI functioning, suddenly it makes perfect sense why infant stool is naturally loose, while adult stool is formed.
On to Section 4, Structure, Skin, and Protection. Basically, the body's armor.
When you're doing pediatric skin assessments, you're going to encounter very specific conditions like tinea capitis, which is a fungal infection of the scalp. These presentations are totally distinct from what you typically see walking the halls of an adult med-surg ward. Because their skin is fundamentally different, infants are uniquely susceptible to conditions like Liner's disease or scleroderma neonatorum.
So why is their skin so susceptible? Well, it all comes down to pediatric integumentary immaturity. A child's skin is just significantly thinner than ours. Even crazier, their apocrine sweat glands are tiny and basically non-functional from birth right up until the preschool years. Actually, they don't really start working properly until around 8 years of age. This literally alters how a young child regulates their body temperature compared to a sweating adult, which completely changes our nursing interventions when dealing with fevers. And this brilliantly illustrates the musculoskeletal side of things. At birth, the sutures in a newborn skull are totally ununited, which allows for rapid brain growth. Plus, an infant's bones are firm, but they aren't nearly as brittle as an adult's. Because they're a bit more pliable, fractures are actually pretty rare in infants. And when they do happen, the rapid cellular division means they heal remarkably fast. Also, remember that children grow at the epiphyses of their bones, a process that completely stops once we hit adulthood. Section 5. Neurological and cognitive development.
300 to 500 grams. Think about that for a second. That incredibly small number is the total weight of a neonate's brain. To put that into perspective, a mature adult brain weighs between 1,300 and 1,400 grams. This stark contrast highlights the massive, exponential growth and maturation that has to happen throughout childhood. Because of this initial immaturity, a newborn's vision isn't fully developed, and a lot of their actions are purely reflex-driven. Reflexes that will eventually fade away as their brain grows and they develop voluntary control.
As that brain physically grows, so does the child's cognitive capability, beautifully mapped out by Piaget's cognitive development stages. We start with the sensory motor stage from 0 to 2 years, where an infant learns through direct sensory contact and experiences pretty severe separation anxiety. Then we move into the pre-operational stage, which is all about pretend play and egocentrism, up through the logic of the concrete operational stage, and finally into the formal operational stage, where adolescents can actually reason abstractly. As a nurse, you have to tailor your explanations to whichever stage your patient happens to be in.
But it's not just about raw cognitive reasoning. We also have to consider the profound social and emotional impacts of our care. A child's world is actively being shaped by bonding with their parents, their peers, and their school environment. An adolescent who is dealing with identity confusion and peer pressure is going to handle a hospital stay drastically differently than a toddler who's just exhibiting negativistic behaviors, right? The hospital environment completely disrupts all of this normal social development. Part of your job as a holistic nurse is to support that emotional growth right alongside their physical healing.
Which brings us to our final section. Section 6. Pathologies and clinical takeaways. Time to apply this.
I really want you to critically think about this question. How do all these systemic differences directly alter pediatric pathology? All that thin skin, the immature nephrons in the kidneys, the rapid heart rates, the small airway passages, how does all of that change the way a disease actually manifests and progresses in a child compared to an adult patient? So the crucial point is this: a child's disease presentation is fundamentally different. Period. Because of those immature kidneys we talked about, pediatric patients are at a remarkably high risk for rapid fluid and electrolyte imbalances. Because of their developing immune and lymphoid systems, which are growing rapidly up until about age 11, their overall resistance to disease is just different. The signs and symptoms you are looking for will simply not mirror the textbook adult presentations. You have to be hypervigilant and constantly aware of their specific developmental baseline.
Which leaves us with one final question. Are you ready to look at every single pediatric patient through this vital developmental lens? Treating children is an absolute privilege, but it demands that you be adaptable, highly observant, and fiercely knowledgeable about how their rapidly growing bodies and minds actually work. Keep these physiological and cognitive realities at the absolute front of your mind in your clinical practice, and I promise you are going to be an outstanding advocate for your young patients. Thank you so much for joining me for this explainer, and keep studying hard.